The content is not a substitute of professional medical advice, diagnosis, or treatment. Always seek the advice of a physician for any questions you may have regarding a medical condition. Hello and Namaste. It's me, Bipana Gurung.
And it's me, Samit Lamichanne.
First of all, I would like to welcome you all to yet another episode of our podcast brought to you by Creative Callosum Nepal.
In this program, we will be discussing about various diseases which we have encountered during our clinical postings. Without further delay, let's move on to today's discussion.
Okay, a 6-year-old boy, permanent resident of Bharatpur, was brought to our institution via emergency by his parents with chief complaint of right ear ache for last 3 days and fever for last 2 days. His parents stated that initially the pain was mild, throbbing in nature, acute onset, non-radiating and associated with hearing loss, restlessness and irritability. Pain was aggravated at night. Later, pain gradually became excruciating and the child kept tugging his ear. He also had fever for last 2 days, which was measured to be 102 degrees Fahrenheit. His mother stated that he had cough and a runny nose for about 5 days, which has been treated with nasal spray and home remedies. There is no history of ear discharge, itching, and injury to ear. There is no history of headache, neck rigidity, chest pain, vomiting, abdominal pain, diarrhea, frequency, urgency, or dysuria. Furthermore, it is found that both his father and grandfather smoked cigarette and he had similar episodes of illness when he was only 3 years old. So, based on this history, what do you think? What might be the possible diagnosis?
Here is mentioned in the case summary, the boy had excruciating earache which was throbbing in nature and associated with fever, hearing loss without ear discharge and itching. So in my point of view, this could be the case of acute otitis media. In acute otitis media also, patient present with similar clinical feature. Here age of the patient further support the diagnosis of the otitis media. It is more prevalent in infants and young children. Infection might have spread via station tube following an upper respiratory tract infection. Diffuse otitis externa and bullous meningitis are also important differential in this case. Here, severe pain, hearing loss, and fever suffered for it. What about you, Bipana? Do you want to add some differential in this case?
Yes, other conditions like cerumen impaction, dental abscess, foreign body in ear canal, and referred pain from parotid gland, tooth, and lymphadenitis also have similar presentation. So, we need to perform additional investigations to reach our final diagnosis. What investigations will you order to further support your diagnosis, Samit?
For such cases, tympanic membrane examination with pneumatic otoscope, examination of nose and pharynx, hearing tests, radiology of mastoid, and microbiological studies for any ear discharge should be carried out. If possible, CNS examination by CT and MRI for any cranial pathologies and culture and sensitivity for discharge can be done. We already have the report for this case, right?
Yes, here I have the reports of hearing test, pneumatic otoscopic examination and mastoid radiology, which states that there was conductive hearing loss in right ear of the boy. Pneumatic otoscopic examination revealed red and bulging tympanic membrane. Handle of malleolus is engulfed by the swollen and protruding tympanic membrane, leading to impairment of ossicular landmarks. Tympanic membrane is thickened, hyperemic, and immobile, whereas mastoid X-ray showed clouding of ear cells because of exudate. Nose and pharyngeal examination showed sign of upper respiratory tract infection.
Hence, on combining history and examination findings, what seemed to be the probable diagnosis?
It appears to me that our diagnosis is acute otitis media, severe pain of acute onset, and fever following upper respiratory tract infection, conductive hearing loss, and red congested tympanic membrane with loss of normal ossicular landmarks and mobility strongly suggest inflammatory and infectious disease in middle ear, that is, acute otitis media. Lack of any ceruminous impaction, ear discharge, itching, and any abnormality in external ear exclude the possibility of important differentials like otitis externa and cerumen impaction.
I totally agree with you. Acute otitis media is second most common clinical problem in childhood after upper respiratory tract infection, which further supports our diagnosis.
So, what might be the treatment modality for this case?
In this case, we should go for antibacterial therapy, as the most common organisms are Streptococcus pneumoniae and Haemophilus influenzae. The drugs effective are ampicillin 50 mg per kg per day in 4 divided dose and amoxicillin 40 mg per kg per day in 3 divided doses. In those who are allergic to penicillins, cotrimoxazole, cefaclor, or erythromycin is given. It is continued for 10 days minimum till the tympanic membrane regains normal appearance and hearing returns to normal. Likewise, nasal decongestant drops like ephedrine should be used to relieve eustachian tube edema and promote ventilation of middle ear. Oral decongestant can also be given in case of difficulties. Other modalities are providing analgesics and antipyretics to relieve the pain and bring down the temperature. There is a procedure called myringotomy as well. We studied about this in our last lecture at class, so I think you can explain in short about it.
As far as I remember, firstly, we should review patient after 48 hours of medical treatment. If earache is present and fever subside, then same treatment as you mentioned should be continued for 10 to 14 days. If pain and fever both persist after 48 hours, myringotomy is indicated. Basically, it is incising the tympanic membrane to evacuate pus and indicated when membrane is bulging with acute pain, in persistent conductive deafness despite treatment, and if there is persistent effusion beyond 12 weeks. So, special care should be provided after the antibiotic treatment as well. We discussed a lot about acute otitis media. What could be possible complications?
There are many dreaded complications of otitis media. It has extracranial complications, which includes acute mastoiditis and mastoid abscess, labyrinthitis and labyrinthine fistula, facial nerve paralysis, periostitis. Likewise, intracranial complications are pyogenic meningitis, lateral sinus thrombosis, extradural and subdural abscess, and brain abscess as well.
In this episode, we discussed about the case of acute otitis media. Thank you for listening patiently. Don't forget to like, comment, share, and subscribe. We will be back with another episode. Until then, have a good time.